Hi there, this is Dr. Philly, and we're going to go over a case of the day here. And this is a pelvic ultrasound. The history was a patient with previous endometrial hyperplasia and previous history of breast cancer. And to my knowledge, the patient is not on any current hormonal therapy, but that history, of course, was not given, as it often isn't. Um, and it can be important, but in this case, we're just going to go ahead and read it as if the patient is not on hormonal therapy. So initial sort of large field of view, transabdominal imaging, we're measuring the uterus. There's clearly sort of an exophytic, presumably a myoma here. And moving on to the endovaginal scan. Sonographer's measuring a structure here. Here you can see the endocervical canal. So this is essentially the end of the cervix here. So this is a Nabothian cyst, not really worth mentioning and certainly not worth measuring. And moving forward, so I haven't looked at any cine clip images yet, but to me this looks like it's probably the endometrial canal. And if we throw a measurement on it, 7.9 millimeters. But I notice here the sonographer is measuring the endometrium, and I'll move this down a little bit so you can see she's measuring it at 4.1 millimeters. So we may be disagreeing here. We'll have to look at that on further images, but always something to be really careful of. Make sure the endometrium is measured at the maximal thickness, and you want to make sure that you see the entire endometrium and that you measured it at its maximal thickness. So there's a fibroid here, and it's left-sided. It's anterior. It's probably, it's hard to say. Is this lower uterine segment? Is this mid-uterus? That's why it's helpful if you're a sonographer to label this appropriately for the physician, because you can't always tell. I mean, we can kind of scroll through cine clips and look at all this stuff, but it's really helpful to sort of document that either in a report or just right on the scan itself. Again, is this mid-uterus, lower uterine segment, fundus? I have no idea, just looking at these pictures. And here's this other fibroid that we saw earlier on the transabdominal scan. Here it's left-sided fundal, and it looked subserosal. So here we've got left-sided fundal subserosal myoma. So there we're in pretty good shape as far as getting a good description on it. And this is a pretty classic looking fibroid. Measuring the left ovary, and we see there's a little cyst. It looks unilocular and anechoic, and it's measuring around 9 millimeters. Let's see if we get a full measurement on this thing. So actually in one dimension measures 1.2 centimeters, and that's actually important for going to be important for our recommendation, given that this is a postmenopausal patient. Here's a more typical appearing postmenopausal ovary, very homogeneous, no follicles, no nothing. Has normal flow characteristics. Again, I get the sense that we're not measuring this endometrium in its full amount. We're going to remeasure the uterus here. So uterine size is okay. Endometrial thickness was a 4.8 millimeters maximum, but we're not really sure about that. She felt like, so there was this left ovarian follicle, tiny endometrial cyst. I didn't really catch that. We'll have to go back through that on some of the cine clips. There was a simple cystic lesion of the left ovary, and So actually that thing that we felt, that's why she was measuring it, felt like that was another fibroid, a 9 millimeter fibroid. I think that was actually in the cervix, and I think that's actually um, that was a Nabothian cyst. So let's pull up some cine clips here. We'll kind of scroll through this. Um, Here's that lower uterine segment, sort of cervical lesion. Um, Again, could that be a little cervical myoma? Yeah, sure. Doesn't have the best acoustic enhancement. Does it really matter either way? No. Um, so I still think it's probably a little Nabothian cyst. Little cine clip of the right ovary, probably not worth going over. Cine clip of the uterus again. So let's take a look. We were going to check into this endometrial canal measurement. So you can already see that, you know, we're not really seeing the endometrial canal beautifully, but as we get through right here, that's kind of that picture we saw earlier. Try and make a measurement on it. And we're getting 7.2 and 8.4 here. Okay, so I think the endometrial canal is closer to 8.4 millimeters, which in a postmenopausal patient who is on hormonal therapy, we'd probably be okay with that. Not on hormonal therapy, um, we'd want to find out whether they're bleeding to decide whether or not we really want to move forward on evaluating that. She has a known history of endometrial hyperplasia according to the history, so maybe she's been biopsied before. We don't have a comparison. So depending on what the real history is, it's going to depend on what we would want to recommend. But if it's an 8 millimeter endometrium, the patient has a known history of endometrial hyperplasia, so she must have been biopsied in the past, we would probably just leave it up to the doctor at that point and not really go into any extensive recommendations since we don't know the history. Which leaves the only thing left is that 1.2 centimeter unilocular anechoic cyst in the ovary. Now, unilocular anechoic cysts are almost invariably benign, and um, the postmenopausal ovary does occasionally uh, still produce some follicles. Usually earlier on in menopause. This patient was 60, so we don't really know when she became postmenopausal. I don't have her actual last menstrual period, but the SRU guidelines make it pretty easy on us, and if there's a postmenopausal cyst, unilocular anechoic, um, after a postmenopausal patient and it's over 1 centimeter, we're going to recommend a 1-year follow-up. So for that, we'd recommend a 1-year follow-up. She's got the 2 fibroids. Those wouldn't necessarily need any significant follow-up. So we've got the 1 centimeter, greater than 1 centimeter cyst. We're going to recommend a follow-up in 1 year. And we're going to just kind of toss the endometrial uh, canal assessment back into the obstetrician's uh, court to decide what they want to do, since they obviously have some more history regarding that. So hopefully this was somewhat educational. Thanks a lot.